we have Dr. Levon Nazarian, who will be demonstrating the musculoskeletal live demonstration with us. We want to thank Philips for providing the support by providing an ultrasound equipment for this demonstration. So Lev, please proceed.
Okay, so particularly for the people who do not do ultrasound for a living, but also for those who do not do musculoskeletal ultrasound for a living, or even for those who do. What I'd like to do for the next half an hour or so is to show you the mechanics of how we do a musculoskeletal examination, and along the way point out areas which, going with the ultrasound first theme, that really ultrasound should be the way to go as the first and sometimes the only modality for evaluating various structures. Now I was thinking about it. The way I'm going to do this is I'm going to do it with the thing that gives me the highest elevation in blood pressure when people order an MRI first. I'll start with that, and then go to the areas that are not as that there can be a little bit more debatable. But I'll tell you that probably the one area that I don't know why MRIs are ever done is for evaluation of the Achilles tendon. Because the Achilles tendon is very superficial. The structure can be seen extremely in great detail. And we've talked a lot about the resolution, detail, et cetera, but I now just want to demonstrate how we do an examination of the Achilles tendon. So actually, if you can lie on your stomach, please. So it's important to understand that when we do an MRI of an Achilles tendon, the tendon will appear black on the MRI, and that's basically because tendons are made up of a fine fibrillar pattern that just does not show up well on an MRI. But on ultrasound, we rely on this pattern to be able to show us both health and disease. The Achilles being so accessible, so close to the skin, it's really a natural for the evaluation under ultrasound. So basically, we have the patient lie prone, and I just put a little bit of dorsiflexion on the foot. And what I wanted to show you with this, with the image of the Achilles here, is the beautiful fibrillar pattern that we see within tendons under ultrasound. So to orient you, let me get a pointer here. Okay, so this is superior to the left of the image, inferior to the right. This is the calcaneus here, and this is the Achilles tendon coming to insert onto the calcaneus. And what we can see is, rather than a black structure, we're seeing a structure which has a lot of internal architecture to it. I mean, you can practically count the fibers within this tendon and notice their health and whether they're in continuity with each other. We can also see the surrounding soft tissues around the Achilles and see that the Achilles goes from this direction to this direction. And then we can also follow that all the way up. So we start at the calcaneal insertion, and we can follow the Achilles up all the way throughout its course here. And then right about at this level, we're seeing muscle coming in. So you see both tendon and muscle. So we're basically at the musculotendinous junction of the tendon, and then we can continue up superiorly until the tendon basically goes away, and all we're left now are the muscles underneath it. We can then look at that tendon not only in the long axis, but we can turn then the probe into the short axis and get a transverse or axial view of the tendon. Now in this direction, rather than a fibrillar pattern, we will see what we call a brush pattern, almost like a fiber optic cable, where we see this tendon here, again with very exquisite detail, and we can actually zoom up on that tendon there and show just some very exquisite internal architecture within that tendon, so that very subtle abnormalities can be detected and characterized in this tendon, and then again we can follow it all the way up. Now if we had seen pathology such as a tear, it would then be, we could even add information in terms of, let's say it's a full thickness tear. We can tell how far the edges are retracted. We can tell if there are any calcium deposits, any inflammation around the tendon, et cetera. So this is an examination that literally takes just a few minutes and is 100% diagnostic, and in fact probably even better than an MRI in that we can also correlate directly with the patient's symptoms. Now, I'm also going to show you a little bit of the operator dependence of ultrasound for musculoskeletal system. Because in the musculoskeletal system, the angle at which you image a structure is critical. So I have the tendon here, and I see the fibrillar pattern. Now watch when I go to the wrong axis. If I go away from 90 degrees, the tendon turns black. And this is a phenomenon known as anisotropy. So see that black, and now I fill it back in by rocking the probe back and forth. So this anisotropy is an important phenomenon to recognize, and it's one of the reasons why MSK ultrasound is so operator dependent. But it also, once you learn to correct for anisotropy, you'll do it without even realizing you're doing it. Just like everything else, every other technique that you learn, once you learn how to correct for these issues, then you'll be fine with it. Now, it's not just the Achilles tendon. I'm going to switch probes now. But all the ankle tendons, actually, ultrasound really should be the test of choice, because just like the Achilles, we're able to see the structure of all the tendons with great detail. You just turn a little bit on your side here. Okay, so for example, the second most commonly injured tendon in the ankle after the Achilles is the posterior tibial tendon. And what I'm showing here is the transverse and then long axis views of the posterior tibial tendon. And the beauty of tendons is that they have the same signature all over the body. They again have these alternating bright and dark lines that identify the normal tendon architecture, and then you can follow the tendons all the way from their origin to their insertion. In this case, the PTT inserts to this bone called the navicular bone in the foot. Deep to that, there's a ligament called the spring ligament, which also, an injury of the PTT often occurs also with the spring ligament in people with painful flat foot. And so you can actually use the probe to look at both the tendon and the underlying ligament, both of which can create a painful flat foot pathology. Now notice here I'm using a 15 megahertz probe. So the images I had with the Achilles were with the 12. I've now bumped up to 15. So again, look at the incredible detail that you can see within these tendons. What I can also do is I can correlate with symptoms. So if there's an area that I'm not sure is the cause of symptoms or not, I can palpate, or I can put on the color Doppler. Normally, tendons do not have any flow under color Doppler. So if I put on the Doppler and I see flow, I know it's abnormal. Lack of flow is not as helpful, but presence of flow definitely can tell you that there is pathology there. Then by the same token, we talked about plantar fascia before, and plantar fasciitis is a very well seen pathology. The plantar fascia looks very much like a tendon, and there it is attaching to the calcaneus. So right here is the calcaneus, and here's the plantar fascia. Now this gentleman is a dancer. And that plantar fascia, I promised him not to see anything terrible when I scanned him, but the fascia is bowing a little bit over there, so I just want to get a little bit of a measurement, and then I won't tell you if it's normal or abnormal. No, but it's actually it's fine. It's actually within normal limits, so you're good, pal. All right, and we can follow that all the way. Now, one abnormality in the ankle that is really helpful in terms of the dynamic imaging is a phenomenon called peroneal tendon subluxation. So the peroneal tendons live on the lateral aspect of the foot. So if you can turn this way. And our foot surgeons were noticing that they were getting a lot of MRI examinations that were non-diagnostic because there's a thin membrane over these tendons, and if that membrane is torn, the tendons will have abnormal motion. Well, you can't detect the abnormal motion on an MR, but on ultrasound you can very well. And so and that combined with the fact that surgery is usually the only way to fix a peroneal subluxation, we became very interested in the evaluation of these tendons. So these two tendons live like two pancakes right behind the bone. So here's peroneus longus, peroneus brevis, the two peroneal tendons, and that's the fibula at the lateral aspect of the ankle. And let me just bump my frequency up a little bit and move my focal zone to where it should be. All right. So these tendons live on a groove right behind the bone here, and that's their normal position. However, like I said before, there's a very thin membrane that covers them. The membrane's almost imperceptible. But what we need to do is, in order to know that these are normal or not, we can't just rely on a static image. We have to put things in motion. So if you go, so there's the membrane actually seen better. So this is, if I bring the pointer up here, this little thin structure here is the membrane that has a very important function, and that's keeping the tendons from flying out away from the bone. So what I'm going to have you do is just make some slow circles with your foot. Just draw circles. Now see how the tendons move when he does that. Now keep making circles, going around. And see how the tendons, they flop around a little bit, but they don't come up over. I just got off of it a little bit. Let me come back. OK, go ahead. But what they don't do is they don't come up that, there's sort of a ridge, looks like snow on a mountain, sort of a mountain peak there. They don't come up and over that mountain peak. So that membrane is successfully holding these tendons back, okay, you can relax, and preventing them from what we call subluxating over the bone. I can't tell you how many times an MRI comes back negative in this location because this is the pathology, and there's no way to see this pathology without dynamic imaging. And this membrane is so tiny, you're not going to be able to see a tear of that on MRI, so you're not going to be able to see. Now, just to give you an idea of the resolution, you know, this membrane looks like this huge, thick structure that's holding the tendons in. And I'm just going to measure it just to show you what size it is. It's about half a millimeter. Half a millimeter, okay? I mean, it's taking up like half the screen, yet it's only a half a millimeter structure. And so that just shows you the type of detail you can see on ultrasound, and it also gives you an appreciation for how small a structure can have such an important function in the ankle.
What megahertz is that?
This is a 15 megahertz probe. The question was that. So we've come to really rely on ultrasound for the ankle tendons, and it's definitely the test of choice. So any kind of MRI that's done, I mean, I think it's pretty much safe to say that I don't think, if your main question is there a problem with the tendons of the foot and ankle, ultrasound's the way to go. And I think that any MRI is wasteful. It's just as simple as that. However, how does most of the world image? They image it with the MRI, and then what I'll get is our referring surgeons or podiatrists or what have you will have this MRI that's non-diagnostic, and they'll say, can you please tell me whether everything's okay? And then they'll get the ultrasound. Well, meanwhile, and you know, we're talking a lot in healthcare about paying for outcomes. You know, so you know, it's amazing to me that, you know, so we'll have an MRI that's non-diagnostic, and then a limited ultrasound, which the professional fee is something like, what, 14 bucks, 13 bucks, makes the diagnosis. The MRI, they don't get paid to make the diagnosis or not, they get paid to do the study. They do the study, they read it, they put the reading on it, but for making the diagnosis, we get basically pittance. I mean, I could, you know, flip burgers at McDonald's for a couple hours and make more money if that were my main motivation, but that isn't. Okay, so that's basically, so my blood pressure goes highest when I get those. Now the next thing would be we'll go to the shoulder next. So why don't you sit on the side of the chair and just let your legs dangle down this way. All right, so I already showed you the meta-analysis that we did before showing the utility of ultrasound versus MRI for the rotator cuff. And for those of you who are not physicians, the rotator cuff is a very important set of 4 tendons in the shoulder, and we hear a lot about it, obviously, because it's a very important injury. Now, we're about to publish a paper in radiology on the diagnostic algorithm from the Society of Radiologists and Ultrasound Consensus Conference, which really puts ultrasound in the center of the workup for rotator cuff pathology. What I just want to demonstrate to you is how rotator cuff ultrasound is done. And there's a lot of sort of naysayers about, well, you know, impossible to learn, et cetera. I'm just going to show you the technique. And it's really something that, you know, my own personal bias is that learning to find a stone in the distal common bile duct is about 2,000 times harder than finding a rotator cuff tear, because you're using a high frequency probe on a very superficial structure. Okay, anyway, so what we do when we look for the rotator cuff, the first thing we identify is the biceps tendon. So let me get my pointer here. So I just have here the deltoid muscle, which is better than my deltoid muscle, I can definitely tell you that. This is the greater tuberosity, this is the lesser tuberosity, and this is the biceps tendon. which sort of comes down here, and he does have a trace amount of fluid around it, but that can be normal, and probably is. And we come down, because I promised him I wouldn't see anything abnormal today. It's fine. Don't worry about it. It's serious. Okay, long axis. Now again, what has come back in? That fibrillar pattern that we associate with the other tendons we've seen in the ankle has come back in and shows us this biceps tendon to great detail. And now one of this image actually points out an immediate advantage of ultrasound in that I told you that fluid around the biceps can be normal. So the question is, when is it abnormal? Well, it's abnormal if it's associated with focal tenderness. I mean, it's really, we have to use the ultrasound to guide our palpation. Now, this has a correlate, for example, in the abdomen where we use palpation to help decide whether a gallbladder is diseased or not. We push on the gallbladder, see if it's tender. Well, ultrasound-guided palpation is what we do a lot of in the MSK system. So here we see a little bit of fluid here, this dark area that's deep to the biceps tendon within its sheath. Usually it's a normal variant. But what I'll do whenever I see it is I'll press on that area and I'll say, does this hurt? And if it doesn't hurt, I just move on, knowing that because the job of tendon sheaths is to lubricate the motion of a tendon, a little bit of fluid is normal. Okay, so after we identify the biceps, now we're going to move on to the rotator cuff itself. Now there are 4 tendons. One of them attaches to the lesser tuberosity in the front of the shoulder, and the other 3 to the greater tuberosity in the back. So patient positioning is very important here. So what we do is we'll have him externally rotate his arm, and when we do that, it brings out the subscapularis tendon, which is the single tendon that attaches to the lesser tuberosity, which is this bony landmark here. Now, all the tendons of the rotator cuff, you'll I hope notice that they have a slightly different look to them from the other tendons we've seen, because all the fibers on the rotator cuff are not exactly parallel like they are in, let's say, the Achilles or the biceps. Instead, what they have is sort of a bird's beak type appearance. So this is lateral, and then medial on the other side. And you can see this sort of parrot beak. That is the subscapularis tendon. And then again, the deltoid over that. So we are able to take the patient and move back and forth into different degrees of external rotation and really examine that entire tendon from top to bottom. And the beauty of this is, just a clinical correlate, is that this is the tendon that very commonly tears after shoulder replacement, because this tendon has to be divided for the surgeon to get exposure into the shoulder joint. And again, I can't tell you how many times I've seen MRIs of a postoperative shoulder that's painful. The shoulder prosthesis has distorted the field. You can't really see much. And then they come in for the ultrasound, and we diagnose the tear of the subscapularis tendon. Next thing is we have the patient take their hand and put it on the back pocket. And then in this position, we see the bird's beak appearance of the remainder of the rotator cuff. So there's the supraspinatus, which is basically the most important of the rotator cuff tendons here. And then as I translate the probe back posteriorly, we get into the infraspinatus. Now, as I was going, there are certain areas that looked black, such as here. What I do is I tilt the probe and make that go away. That's just angle. That's the so-called anisotropic effect. So we can get longitudinal and then transverse views. The rotator cuff looks pretty much like a tire on a wheel. And I'll get that without the anisotropy. So you can see that this is basically, you can relax your arm. So this is the head of the humerus, and you can see the cuff nicely covering. This is tendon. This is, again, just the anisotropy based on the angle. And then the bursa, and then the deltoid as well. So the whole examination of the rotator cuff per se takes just a couple of minutes. And then we also have, in order to do a complete shoulder, the AIOM has a guideline jointly with the American College of Radiology that what should be in each shoulder examination. But so the rotator cuff certainly is one area where shoulder ultrasound is very, very important. And again, this is my own personal opinion now. It's not guided by anything except just feeling and intuition. But I don't understand why rotator cuff MRI is still paid for at the rate it's paid for when you have an equivalent examination that costs a small fraction of the cost. And we might say, well, because MRIs of the rotator cuff are a lot easier to read. Well, not really. I mean, again, we see a lot of misread musculoskeletal MRIs on the outside. So this is one area that I also am sort of miffed that we continue to pay for MRI of the rotator cuff when nice interactive examination with the patient that they prefer, that's much less costly, gives you the same answer, almost equivalently. Now, one thing that you can also do, though, while they're here, so, okay, that's the rotator cuff. Now, there are certain areas I want to say you can't see well on ultrasound, the labrum, for example. So in the younger patient population who tend to get labral tears, you still want to do the MRI with MR arthrography. But if I have since rotator cuff disease increases with age, I mean, if I have an 80-year-old patient who has a lot of shoulder pain, doing an MRI is a complete waste of money. There's a high chance it's going to be rotator cuff pathology, probably about 80% chance there is. And then you can, once you have the patient there, you can inject them, you can treat them at the very same time, instead of the MRI, which is very inefficient. They get the MRI, the report gets back to the doctor, they make another appointment, they see that doctor decides, do I treat this, send this out, et cetera, et cetera. Meanwhile, you get a one-stop shop if you do the ultrasound first, because you can add the interventional piece. The next thing you can add is the dynamic imaging. So actually sit with your legs dangling off of that side. Many of the shoulder pains that we see are dynamic in nature, and the static imaging just won't show it. And one of the most common pathologies is the subacromial impingement. Now, the acromion is the piece of bone that juts out, and you can all feel yours. It's as you slide your finger across your shoulder, it's that little ridge at the very end. And it turns out that the rotator cuff has to go under that ridge during its range of motion in order for the shoulder to function normally. Now, I've seen a lot of MRI reports saying findings consistent with subacromial impingement, which is ridiculous because you can't see impingement. It's a dynamic study. So people have written articles saying, well, if you see this and you see that, it usually means they have impingement. Well, you don't have to do any kind of conjecture or whatever. Just put the probe on top of the acromion, and let me just orient you as to what we're seeing. So let me make sure my focal zone is good. And here's my pointer. So this is the tip of the acromion, and here is the rotator cuff with the greater tuberosity. Now, the rotator cuff is mostly already under the bone because notice I have his arm in front of him. When I wanted to see the rotator cuff better, I had to pull his arm back. But in any event, we certainly see it well enough to look at the motion of the shoulder. And then what I'm going to have him do is just reach for the side and see how that bone slides very nicely under the acromion. Come back down. So again, we're focusing on is this area right here, which is the area of the rotator cuff. This is the rotator cuff. This is the greater tuberosity. In a healthily functioning shoulder, this should come this way and come very smoothly under this bone. Let me just do it here. And see how nice and smooth that is. And you can go all the way up. So very often, we'll see something blocking that motion, whether it be a calcium deposit, bursitis, or what have you. And so we can absolutely say, A, that they have impingement, and B, this is what's causing it, and C, by the way, we can break that calcification up for you and make it go away. So it's diagnosis and treatment, all in the same visit. Okay, next thing where ultrasound really shines is in ligaments. Ligaments are very commonly injured all over the body, and ligaments hold bone to bone. So if you have a static image, you can tell whether the ligament does not look right, but you can't tell if it's functioning correctly or not. And the one area where this is really important is in professional baseball pitchers, actually all baseball pitchers, but where we use it very, very often is in professional baseball pitchers. Because we published a study years ago that almost all pitchers will have some degree of ligament degeneration asymptomatically just from throwing pitch after pitch after pitch over many years. So what we were frustrated by the fact we would see all these abnormal ligaments in pitchers and not really know if it was the cause of their problem or not until we came up with the idea, well, look, when you throw a pitch, what's that ligament do? It basically holds your bones, prevents them from flying apart. Let's mimic that activity and see whether the ligament is able to hold the bones together or not. So just to demonstrate, if I come down to the elbow here, and elbow injury is the most common cause for a major league pitcher to end the career. You hear a lot about rotator cuffs, et cetera, but by far more common are problems with the elbow ligaments. So what we do here, and I'll just orient you, is we identify a few structures. This is the ulnar collateral ligament, which is the star of the show. This is the ligament that stabilizes this joint between the humerus and the ulna and prevents it from opening up. This is the overlying muscle and tendon. So this is where all the money is. This is the joint that becomes way too lax in a baseball pitcher if it's injured. And what we do is we place stress on that ligament. I'll do it with one hand here, but generally what we do is we put them in, either we have a second person provide the stress, or we put them in a special machine that gives them a measured amount of stress. And we basically look to see whether this joint opens up between stress and rest. So we measure this joint before and after stress, and we've come up with parameters by telling what's normal for a major league pitcher and what's not. To the point that I have this nice gig that I've had now for, this will be the 13th year, is I go down to Philadelphia Phillies spring training every year, and we scan the entire minor league system, every pitcher in the minor league system. So the Phillies typically have between 80 and 90 pitchers in their minor league system, and we do bilateral ultrasounds of their ulnar collateral ligament without and with stress. Stress on me the whole time. We start at like 6 in the morning, we go to noon, next day start 6 in the morning, go to noon. And the reason we do this is because we want to identify preclinical ligamentous injuries that may need some rehab before the season, or perhaps alter their biomechanics so that they don't have that kind of those kind of injuries. So this has become sort of the standard for evaluating the ligament in the elbow. And we now have a grant from Major League Baseball to really fine-tune which part of the ligament is the most important in the stabilizing of the elbow. So we now take that concept, and now whenever there's a ligament anywhere in the body, I stress it to see whether it's doing its job. It's not just how it looks, it's what it's doing. So if you can lie back down, again, please. So a very commonly sprained, the most commonly sprained ligament in the body is the anterior talofibular ligament in the ankle. Just bend your knee up. And so, ankle sprains are not that hard to diagnose, certainly in the acute setting. But sometimes we're faced with a patient who has a lot of pain in the lateral part of the ankle, may or may not have remembered ever hurting it, and gets an imaging study, and let's say they've sprained it before and the ligament may not look completely normal. Here's the fibula and here's the talus. Yours looks fine, but this is the anterior talofibular ligament. But what does a static image tell me here? It tells me nothing, absolutely nothing, because I need to know what that ligament's doing when I stress it. So I take my hands here and I pull in the direction of the ligament. Let me get more gel here. So I'm pulling in the direction of the ligament. And what's happening is I'm not able to pull those bones apart. So that is a competent ligament. But I'll tell you that last week I had a patient where the ligament didn't look that much different. It was a gymnast who was having ankle pain. And when I did that stress maneuver, the bones just flew out from each other. And the MRI was not very helpful because it couldn't detect that, because it's a dynamic there's a dynamic study, and ligaments do dynamic things. So that's what they're there for. Okay, next thing, just a couple others I want to hit before we finish. We see a lot of patients with hip pain. Now, MRI really is great for the hip. There's no question about it. But again, what they can't see is where the patient hurts. And that is so often the whole ball game. And let me just cover you up here. So we can see the hip, and just pull this down a little because yeah. So very often, and extend your legs out. Good. So very often when we're looking at the hip, we can see the hip joint very well, and we can see the surrounding tendons and ligaments and all that kind of stuff. This is the labrum that I showed you at the lecture this morning, acetabulum, femoral head, the iliopsoas muscle, and all this kind of stuff. But sometimes I'll be spending my time scanning here, and the patient will say, no, that's not where the pain is. And I'll palpate, and no, that's not where it is. It's higher. And so they'll direct me up toward this direction here. These are the inferior epigastric vessels. And then this is the area of the internal inguinal ring. Now, these are the vessels, and if I go laterally, can you just do a crunch sit-up? And then what I'm looking for is anything coming through that internal inguinal ring that might signify a hernia. Come on back. Because the next thing I want to tell you is that common things are common in medicine, and very often people are sent for hip evaluation upon hip evaluation, MRIs, CTs, surgical consults, and what they have is a good old-fashioned inguinal hernia. Now, this doesn't just result in a delay in diagnosis, because I've had 2 documented cases already of patients who have had hip replacements, and their problem was an inguinal hernia. Now, how do I know that? Because they have the hip replacement, and they're sent to me for persistent pain. Typically, the surgeon will look at the x-ray and say, you shouldn't be having pain, everything looks fine. Okay. They go to a non-surgical doctor who sends them for the ultrasound. I go over the area of the hip, it looks okay to me too, and they say, but no, look, it's for years, it's been always in the same place. Go higher, go higher. I go to the inguinal canal, have them bear down, and there's the hernia coming right through. And then I tell them, is this where you've hurt for the last 5 years? And they go, yeah, that's it, that's it. I said, you have a hernia, and then you can see all the color drain from their face. I mean, they're grateful that we finally made the diagnosis, but they're also like, why didn't anybody do this before? Why did I have this multi-million-dollar workup and end up getting an extremely expensive surgery with all these months of rehab, and I had a hernia? And this has happened twice. I've seen 2 hip replacements already for hernias, and I don't think it's going to be the last one, of course, unless we all decide to do ultrasound to evaluate for hernias. Okay, and then just one final thing, and then I'll take any questions you might have. I just also want to give you a sense of how well we can see cartilage. So the knee is another area that MRI is superb, but just to show you again the resolution that we can see in the knee cartilage. Can you bend your knee all the way up? So I've had some people sent to me with sort of idiopathic knee pain, and we have sort of a routine that we go through. But one of the things we always do is we get a window into the knee joint to see the cartilage. As it turns out, cartilage that lines joints, so-called articular cartilage, is very hypoechoic. It looks almost black. It almost looks like fluid. And so this is cartilage. This is not fluid. This is cartilage lining the bone of the femur. This is the part of the femur that actually articulates with the patella. And we see gout, pseudo-gout, erosions of the cartilage. We see edema of the cartilage, et cetera. And again, you may go in retrospect. If you have a pseudo-gout with a sub-millimeter calcium deposit in the cartilage, MRI is not going to see a sub-millimeter deposit in the cartilage. I mean, I've already shown you we can see sub-millimeter structures, but we can. So now, can we see the whole cartilage in the knee? No. We have certain windows we can see and not see. But the bottom line is the patient's there, needs a diagnosis, and you can be there to provide it in a lot of different ways. Okay, that's the time allotted to me, but I'm happy to answer any questions that you might have. I appreciate your attention.